Questions? Any questions from the audience? I've got one, and that is back to your question about how much evidence do we need, and when do we, when is it time to think about not having the preventive diets that are appropriate for people in their 20s and 30s and 40s and 50s. What is your feeling about that in terms of the evidence? Excuse me, Mark.
Well, I think we do have enough evidence. We're not quite as far as nutrition.
Use the microphone.
Press the little button till it goes red.
Yeah, that's probably the right one to take. Yeah, press. So I think we're in very many ways with nutrition where we are with exercise. Exercise may be just a half a step ahead, if you'll pardon the pun, but we don't know exactly what the what is. And we have we know that exercise is better than no exercise. We know that certain foods and certain diets are better than others, and we don't have great precision. And plus, this is hard work. Going on a Mediterranean or DASH diet requires a lot of work. That said, there is a knowledge base, and it's an increasingly good knowledge base. And I think we really are ready to make that step towards having a campaign or some kind of implementation research to try to get people from knowing, first of all, to know about these diets, but second of all, to actually start incorporating them. And now is a good time. The nutrition industry has taken a lot of stuff on the chin because of the obesity epidemic, et cetera, and people are paying attention to nutrition again. It's on a lot of people's minds. So I think it is good time. For when do preventive measures, when should they stop? I think when you start clinically thinking that there is a time frame that a remaining life that is reduced. When you say, geez, I'm not thinking about an indefinite future. I'm thinking of a future of a few years, et cetera. I think that's kind of a telltale that we need to shift our frame of thinking and be liberating about what people can eat.
Thank you, Dr. Geffen. I think Dr. Mork?
Yeah, Tim Mork, Spectrum Nutrition. I appreciated your comments, and I think that your EPS, I spent a little time in hospital settings in the past myself, and I know that it's not a typical medical profession top of mind to think about the nutritional elements, but when you think about the Mediterranean diets and the DASH diets, do you believe that the benefit is what they add that might not be in the standard diet, or what they have reduced that might be in the diet?
Yes. So I think probably it's mostly what they reduce. It may be a little bit what they add, but in fact, these very high-fat diets that people are having and red meat and such like that, getting those down, I believe, probably has the biggest benefit, but I can't be certain about that. It's interesting. It's not easy. It definitely isn't easy. I'm actually a vegetarian, and not really for health reasons. It's more for animal reasons. But being a vegetarian is not an easy thing to do. And to be honest with you, the DASH and not so much the DASH, but certainly the Mediterranean diet, there isn't a whole lot of meat there. And, going to restaurants, it's easier than it was a decade ago, but some restaurants I've had to walk out of because there is nothing for me. There's nothing for me at the restaurant. Siming, how are you?
Hi. Good. How are you doing? Thank you so much for that presentation. So, David, I think with zinc, at this maybe was the arid one. They did show that there was decrease in mortality in people who were. So there seems to be some benefit there. And one of the observations we've made is that there's a good percentage of the Americans who have low serum zinc level, and that could have some health consequences. I think that's something that we should probably keep in mind. The other thing that I want to mention is that there's really no evidence that vitamin E below 200 international unit has any harm, and up to 200 there seems to be some benefit. So I would want to differentiate in terms of the recommendation not to take vitamin E at all or consider it harmful at all levels. I think it depends on the, how much you are supplementing, and certainly, as far as I know, up to 200, even in the meta-analysis, that famous meta-analysis, up to 200, there was actually people who were taking 200 had lower mortality compared to those who were not taking supplements. So I just want to make that differentiation.
That's great. Yeah.
So you can take your vitamin E if you.
I can take it. Yeah. Well, it turns out there's actually it's a therapeutic. It's not a preventive measure. But there was a study that was done a couple of years ago with Alzheimer's disease, and actually supplemental vitamin E, and this was pretty big doses, 1,000 milligrams twice a day, actually slowed cognitive decline. So it may be, as you're saying, threading the needle, finding out what the appropriate dose is for vitamin E. And thanks for the comments about the ARID 1. I was focusing on the cognition one, which is ARIDS 2. Thanks.
Dr. Reuben, you mentioned polypharmacy and the enormous number of medications your patients very often have to take. Could you return to the issue of the additional polypharmacy you get if they're taking 1,000 different supplements?
Yeah,
how do you screen for that?
It's really an issue.
Particularly the drug nutrient interaction.
There are a couple of things with it. Number one is some of those medicines actually interact with other medicines. A lot of them cause increased bleeding. But the other thing is it's just the sheer volume of pills you're taking a day. And I don't know if there are probably some people in this room who take medicines 2 or 3 times a day, and it's really hard to do that. It's a lot of work to remember to take something 2 or 3 times a day. And if some of my patients will be on 8 or 10 or 12 medicines, and remembering 12 medicines plus another 6 supplements, something's got to give. And don't ask me why. Maybe it's because it's California. But sometimes they believe that their supplements are more valuable than the medicines I prescribe for them. And it's just it's a matter of shots on goal. There's so many pills that they're taking, which are the right ones and which are the wrong ones.
Thank you.
Duffy Mackay, Council for Responsible Nutrition. I do represent the supplement industry. So, and I appreciate looking through the disease risk reduction, disease prevention lens. Maybe the evidence isn't as strong. You somewhat downplayed the results of the Physician Health Study 2 with a statistically significant 8% reduction in total cancer, which is meaningful to many people taking a simple multivitamin daily. But I feel like you kind of throw the baby out with the bathwater when you don't underscore just meeting targeted nutrient intakes. Yeah. And the prudent choice was someone who may be limited in their dietary intake. Yeah. A pea protein for an elderly vegetarian, something like that can really help them meet their target nutrient intakes outside of the scope of disease prevention.
I think that's a really good point. And I wasn't trying to bash the supplement industry because I actually oftentimes recommend certain supplements for patients and some things that are herbals. But there are people who aren't getting enough of their basic vitamins in their diet. And those people, I do believe, that would benefit from a multivitamin. And on the other hand, people who have really good diets, probably get all their supplement needs and minerals and vitamin needs. So people ask me all the time, should I take a multivitamin? And I say, it's probably not going to give you a whole lot of benefit, but I'm fine with it. And so I don't proscribe them.
We have, I think this will be the last question, Dr.
Okay, thanks. Naomi Fukugawa from the USDA Beltsville Human Nutrition Research Center. I really applaud your point about the fact that we shouldn't be having people scared of their food, and they eat food, not necessarily specific nutrients. But from the standpoint of trying to find a way to help healthcare providers as well as the public better understand what constitutes a healthy diet, what recommendations would you make from the standpoint of education, research, and communication to try to help achieve that?
That's a really good question. That is such a good question. Doctors in particular, and I like to beat up on doctors because I'm one, but we like to prescribe pills. You know, there's nothing we'd rather do than put an order in for a medication. And it just is incredibly gratifying for some reason or another. And I actually think that's the approach we should be thinking about for nutrition, is to say, my prescription for you here is going to be this kind of diet. And then when you press that button, instead of it going to the pharmacy, maybe it goes to a nutritionist. The nutritionist sits down and with you. But it has to happen right at the level of the primary care doc. Because if they don't have that respect for what good nutrition can do for you, you know, they'd much rather prescribe a medicine.
But you know it's a problem with medical education.
It's a huge problem in medical education. Yeah, it's a huge problem. I mean, that's where it starts. Yeah. And, you know, I think part of it is, and I'm just going to be candid here, is that I think that there's a culture among physicians and a mindset among physicians, and sometimes the people who are teaching nutrition are not in that culture and mindset. So they're kind of using the wrong hammer to drive the nail.
Thank you. That's very thoughtful. And we also must remember the nurses.
And the nurse, yeah.
If you'd like to sit up here, that's fine. If not, sit there. You'll be back in a few minutes. Yeah, you're probably better there. Well, we're lucky. Thank you so much, Dr. Reuben, for coming so far and giving us these wise thoughts.